Not gonna say too much about it, 'cause he's not gonna want all that, prominent and noted. And we are just blessed to have Jarrod Carrol, big memory physician, Kaiser. Become little acts, and I say it all the time, little acts, but a big God. And so I turn it over to you, Dr. Carrol.
So good afternoon, good morning, everyone, actually, all this afternoon. So good morning, as Sharon mentioned, I'm Jarrod Carrol. I am a geriatrician, which means that training and aging, and my focus at the present time is memory loss and cognitive impairment. Today, I try to come here at least once a year just to connect with ACTS, because yes, it is a little group, but it is a big impact, and it's important for me to participate in activities like this because it's an opportunity to bring focus on the people that really do the work. A lot of people think that as physicians, as the medical group, we do a lot of the work, but a lot of it is done on the ground at home. And when you think of, how dementia can impact a person, it's important to realize that it really impacts the family. And so as it impacts the family, it's important for that family to be equipped with the appropriate support to be able to take care of them. So when I have opportunities to take a break from focusing on the patient to connect with caregivers, it's important for me to first highlight and thank you for all the work that you guys are doing on the ground. Because we see patients as a snapshot. We see them where they might be their best because they're going to the doctor, they're going to do this. So they're in a way sometimes putting on for the doctor, whereas you guys see them every day at home, the good, the bad, and the ugly. And so I want to first thank you for the work that you do as caregivers and the role that you play in your loved one's life.
Thank you.
All right. Now, I always like to I like to take a bird's eye view first of what dementia is, because I think when I think of education, the importance of getting information out to patients and families, it's always important to not assume and start focusing on small details, but sort of take a step back and talk about what dementia is itself. Okay. So I think the one thing that we commonly see is understanding the difference between Alzheimer's and dementia. Okay, so I always like to start there. The new way that I describe it, so this may be new for Sharon, but the new way I describe it is dementia is like the last name. So just imagine it's a family of conditions, right? So it's not just one thing. So just imagine your last name is dementia, right? Mm-hmm. And each member of the family, they're all in that same family, but they have a different first name. So the group of conditions, that's dementia, that's the family, that means there's changes in memory and or thinking that impacts the patient to the degree that they start to have functional decline. So things that they previously could do by themselves, they start to need assistance with. So this family of conditions is called dementia. But it's different members of the family. And we know how members of the family can be. You got ones you can trust, ones you can't trust, ones that make you mad, ones that don't make you mad, right? But Alzheimer's is the big brother. So he's the oldest. Most people have Alzheimer's dementia, but he's not the only member of the family. So we can't always assume it's Alzheimer's. But most likely when people have dementia, they have Alzheimer's. Most likely. And why we say most likely, about 70% of people with dementia have Alzheimer's. Okay. But there's 30% that don't. So that 30% is important too. So you think of Alzheimer's being the big brother, you think of Parkinson's dementia. So these are patients that may have some movement changes as well, whether it be a tremor or shuffling gait or changes in their abilities. But so you think of Alzheimer's, you think of Parkinson's, you think of Lewy body dementia, you think of vascular dementia, which is a patient that would have a stroke and that'll cause changes in their memory. You think of worries. It reminds me of back home in Florida. If you think of mixed dementia, which sort of means mixed is like this catch-all. we think they have some symptoms that's like Alzheimer's, but some symptoms that's like Parkinson's. So we'll say it's mixed dementia. But there are various different types of dementia. So I want us to first understand that this is a group of conditions and they're all members of the same family. It matters to a certain degree the type because it can impact the type of medications we can use. But at the end of the day, they all lead to decline in a stepwise format. So you may have some issues at the beginning with your highest level of functioning, and then over time, it will kind of impact you to the degree that you need help with even your basic things.
Yes.
So I think the first thing I always want patients, families to remember is that it's a group of conditions. Now let's talk about Alzheimer's. So Alzheimer's is where you'll get the most bang for your buck. That's where 7% of the people that have dementia, that's what group they're in. Generally speaking, and I speak in generalizations, primarily because everybody's situation will be a little different. Everyone has a different journey. Everyone has a different symptom that brings them to the hospital or to the doctor. But generally speaking, when we think of Alzheimer's, it impacts short-term memory first. So just think it's impacting memory. Impacts their highest in the short-term memory. It's important to realize that we all will have some memory changes. Ain't nobody perfect. And as we get older, there will be some changes in memory. But we get concerned when it starts to impact our ability to be independent. So when it starts to have an impact, so forgetting where you put your keys, that can be very frustrating. I get it. I do it too. Forgetting certain things, forgetting where you put your keys or forgetting someone's name that you don't see as often at church, that can be frustrating because you're like, my kids. Right. But that doesn't necessarily mean that you have dementia. We worry about when it's the memory loss that impacts them functionally. So we try to tie it to something that they do and it starts to impact that. So what examples do we typically see? So we'll see memory loss, they're forgetting to pay their bills. Okay, so that's a direct connection, right? It's not they don't have the money, it's like they're forgetting to pay their bills. Like things, you're seeing that their tax bill isn't getting paid. So every time it's tax time in LA County, it's always like, oh, mom ain't pay her taxes. So that's one thing that we see a lot. So they're forgetting to pay their bills or they're forgetting to take their medications. So that's something that's every day.
Been having been since 20.
Well, it could be a variety of things. So again, I'm speaking in generalizations now. So I don't want you to take this and apply it to your daily life and be like. But what I'm saying is you see a direct connection there. And so you'll say they're forgetting to pay their bills or forgetting to take their medications or forgetting where they're going when driving to routine places. Okay. We might all get a little turned around with all the construction and stuff in LA, but if it's like a routine place that this person has gone to 1,000 years, and y'all know what I mean when I say you've been going there 1,000 years, like when they're starting to lose that ability, that's a direct result of memory loss. Okay, so you want to try to tie those together, right? And so you'll see, so your highest level of functioning, that's typically what's impacted first. So we don't expect people to say, oh, I don't think, I have dementia or we have problems with memory until they're forgetting to bathe themselves, forgetting to dress themselves, because we need to start having these conversations earlier. Now, I'm not saying I want you to go home to your family and, be such a hawk that you're like, your bill was due yesterday. It's not to that degree, but we use those as markers to say that this is definitely being impacted. And once we're able to make a connection that is truly the result of memory that's causing the change in forgetting to do certain tasks, then it increases our risk or it increases our concern that it could be dementia. Now, why do I say it increases our concern? Because every missed payment, every missed dose of medication doesn't necessarily mean the person has dementia. We have to be able to do a few things. We need to be able to rule out other things that can cause the person to present like that. Mm-hmm. Could it be problems with sleep? Could it be problems with stress? Could it be problems with mood, how they feel, other things that are going on in life that can cloud your memory to the same degree? You could be juggling so much that you do forget to pay it, or you forget to take your medications, but it doesn't necessarily always mean that, oh, they forgot to do this and they definitely have dementia. So this is why it's important to have these conversations with your physician And the reason why I think it's always important to first level set by saying we all have some memory loss. I don't want you guys to be afraid to tell your physicians or whoever's on your care team that you're having changes and you're noticing changes, because that helps us be able to have an open and honest conversation with you about what it could be.
Right.
Okay. I'll see people that are coming to the clinic, or I'm seeing them in the community and they feel like, oh, it's not a big deal, or oh, I still can do these things, so I don't want to talk about it yet because we don't necessarily want to be vulnerable. But there are certain things that we need to be able to talk about in the early stages that we need to be able to talk about. We want to be able to engage with you and connect with you earlier so that we can have those important conversations. Does that make sense?
Yes.
But when we hide behind it, or when we sweep it on the rug, when we say, oh, everything is like that just because mom is 75 now, and that's how grandmother was, when we don't have those conversations, then at the end of the day, it can set us up for a more difficult journey. But also it can create kind of strife in the medical community. And I try to straddle the group between the people that I work with every day and the people that I take care of, because I can see it from both sides given my experiences. So if my personal experience is at home. But I think when we don't have these conversations and we're not open with our physician, then as things progress and we've allowed it to be swept under the rug for so long, then when the doctor or someone on the care team is like, oh, I think we're toward the end,
Yeah.
then you like, well, ain't nobody tell me.
Yeah. See.
Like, no, y'all gotta do everything, because this doesn't make sense. Like, no one talked to us about this when we were open and honest about some of the subtle changes that we were seeing. We could have had conversations about that. Does that make sense? And that's with everything, to be honest. Anything's going on. You have a bad headache. I had someone recently that reportedly had been having really bad headaches for years, but it was a black man. He didn't want to talk about it because he didn't want to appear to be weak. Like, he didn't want to feel like he was in pain, and he ended up having a tumor.
Mm-hmm.
All because you don't want to tell anybody you got a headache.
Right.
So it's important and I'm not blaming him. Hey, how you doing? I'm not blaming him and saying, that it's his fault. I'm not saying that, but we need to be able to talk about these things and have an open and honest conversation about these things earlier in the process. Does that make sense?
Right.
So Alzheimer's is the big brother. That's the one that most people will have. When you're diagnosed with mild dementia, oh, sorry, let me take a step back. So I would say the staging of dementia, there are a lot of different ways of staging, a lot of different ways. But the easiest for communication from my standpoint is 4 things: mild, moderate, moderately severe, and severe. You may hear some of my colleagues talking about fast scoring or different ways to classify it. I think it's easy to say mild, moderate, moderately severe, and severe. So mild means that it impacts their highest level of functioning. The memory loss impacts their highest level of functioning, and it only impacts their hands-off care. So things that you can learn to do for them, whether it's paying their bills, doing their medications, cooking, cleaning, washing the clothes, driving them around. That's hands-off. That's not involving their personal care. So that's mild. Okay? Mild dementia. Moderate, they start to need some consideration for hands-on care. You don't physically have to help them, but you need to sort of create a structure where you can help them. So moderate dementia means I may have to start picking out their clothes because they know we're going to church today and they want to wear a swimsuit. You may laugh, but I've actually seen I've seen that occur. The person actually wanted to wear, sometimes they were going to the beach to church. Okay. So you don't physically have to dress them, but you need to sort of like, what you going to the closet for? Like what you're doing there. So that's moderate. So you have to pick out the clothes for them, or you have to pick out the clothes for them because they would say wear the same outfit every day. They don't want to change. They don't have a problem putting it on, but they might take it off and change it to pajamas, but they go put it back on the next day because This is what I'm hearing today. So
Yeah.
that's the type of structure that we create. Moderately severe, so mild is highest level, hands off. Moderate is I need to pick out the clothes. Moderately severe means I need to start helping them get dressed. Okay, because they may put the shirt on inside out. They may put on their socks before, they may put on their shoes before their socks. They may forget to put on underwear. They may put the shirt on backwards or try to put their hand through the arm part of the shirt. So they need assistance putting on the clothes. Then moderately severe has a range. So that's the beginning of moderately severe, but as it progresses, they start needing help in the bathroom. So they may need help with number one or number two, or toileting in general, but they may put all toilet paper in the toilet and flush the toilet or not flushing. All that type of stuff can occur in the moderately severe category. But they're still walking.
Yeah.
Okay, they're still walking, they're still talking, but they just may need some structure and support in certain settings. Whether it's putting on their clothes, bathing themselves, dressing themselves, things like that. So that's mildly severe. Severe, they start needing more definitive hands-on support. Like you definitely have to go in the bathroom with them. Like we don't want them to lock the door. We don't know if they're under the cabinet and looking at things under the cabinets. And they start to have an impact on their ability to communicate. Like their word choice may be pronounced. Now, we all can have some word finding difficulties. Like I can't find the right word, but it's a significant amount when it's the result of the dementia. They're either speaking like garbled speech, like you have no idea what they're saying, or they're saying English words, but I can't process it. I don't know what they mean. So they're getting frustrated because they think you know what they're saying, but you don't know what they're saying. So that is more of the severe stages. And then they start to lose the ability to kind of coordinate walking and stuff like that. That's advanced or severe dementia. Okay. So Alzheimer's, when we think of the staging, all forms of staging in dementia is generally based on Alzheimer's because that's the big brother. But the other forms of dementia can be put on those stages as well. It's just that we have to sort of have an asterisk by it. Like they fit in this stage, but they won't fit completely in the stage. Like in the most common example of that, and which is what we're seeing a lot of people with now, is vascular dementia. So these are patients that have stroke that hit parts of their brain that impacts their ability to function. So those patients with vascular dementia before the stroke, and they can have multiple small strokes or one large stroke. Before the stroke, they were completely independent. They were minding their business, doing whatever they need to do, right? They had a stroke. This is the stroke. And then you saw decline. Often with vascular dementia, we get caught behind the stroke, and we as family and sometimes as providers as well, we get caught behind the stroke, and it takes a little longer for us to diagnose it. Because after the stroke, all hands on deck. Mom can't walk right now. She can't move her left side, so I'm gonna start doing stuff for her. That just makes sense, right? But we don't realize that it's more than just the physical impact of the stroke. It's actually impacting their memory and thinking as well. So often we find it out a little later. So they had a stroke. We all hands on deck. All the girls came to start to take care of mom and start doing this. And then later on down the way, we realized, oh, even if she had to do these things, she wouldn't be able to do it anymore because her thinking and memory is different, right? So sometimes it's hard to stage as far as determining where the patients are for vascular dementia because they could need assistance with bathing because of the stroke. Not that they don't know what needs to be done.
Right.
So when you look at the staging for Alzheimer's, when you say, oh, I need to go in the bathroom and help them, they're in the bathroom, but they have no idea what they need to do. They're confused about how to adjust is it hot or cold? Like what's the right mix? So they get confused about that. But patients with vascular dementia that have a stroke, they know what needs to be done. They just can't physically do it.
Right.
Okay. So you have to be kind of cautious about staging patients with vascular because you'll get confused on is it physical or cognitive or memory and things. So Alzheimer's, big brother. That's the biggest one. Vascular is I like to term it as the second most common, but I like to say that because that's what impacts our community That's what's growing in our community, and that's simply because we're having strokes, poorly controlled blood pressure, poorly controlled diabetes, cholesterol, and so it's increasing our risk for stroke. So I'm seeing younger and younger patients with vascular dementia because they're having strokes. Okay. And then, but technically, the second common would be like Lewy body dementia or Parkinson's dementia. Now, has anyone ever heard of Parkinson's?
Yes.
Okay, so what do you know about Parkinson's? What's one person said they heard about Parkinson's? Tell me what you know about it. So tremors, okay. So Parkinson's and Lewy body, but more so Parkinson's, is a movement disorder. So dementia is a neurodegenerative disorder, so it's memory and thinking. Parkinson's is movement. So when you have Parkinson's dementia, these patients have Parkinson's for a period of time. So their only problem is that tremor. Their only problem is that shuffling gait. The only problem is the slow movement. So it's all movement-based stuff, right? But then over time, they start having problems with their memory. So they had Parkinson's for a while, minded their business, still able to do everything, but then they start having memory problems that impact their ability to be independent. And then you diagnose them with Parkinson's dementia. Okay, so that's another member of the family, right? Lewy body dementia is similar. Okay, Lewy body dementia, they start having the movement changes around the same time they start having the memory changes. Okay, so Parkinson's, they had Parkinson's for 5 years, 10 years. It was something we was dealing with for a while. Then they started having memory problems. Lewy body dementia, they start having movement changes and memory changes within about 6 to 9 months. Like all of a sudden, everything just happened at once. Like they moving slower and they having memory problems. Particularly, additionally, Lewy body dementia, they start having very vivid hallucinations. They're seeing things, they're thinking things are happening that aren't happening all around the same time. Like mom was normal in January, but between January and August, she had movement changes and memory changes. And she was seeing things. Often with Lewy body dementia, they see patients with Lewy body dementia will see little children. They classify everything as little. Like I see little kids running around the house, little animals, little goats, like all like little, like just little stuff. And sometimes we laugh about stuff like this, but it's real because it's like, oh, I know exactly what this is. Because they're like, it's little people running around the house, like, and they're convinced that that's true, right? And it's very vivid and real to them. Because it's like, oh no, I know it's a little child like that's staying in his house. So that's Lewy body dementia. So Alzheimer's is big brother. Vascular, I think its impact is growing at a fast rate because of strokes and things like that. Lewy body dementia and Parkinson's, they both can involve movement, so they can have tremors, again, shuffling gait, slow movements, and hallucinations, seeing things. Frontal temporal dementia. Has anyone ever heard of frontal temporal dementia?
Yes.
Okay, all right. What do you know about frontal temporal dementia?
Bruce Willis.
Exactly. So that's what most people in LA know about it, right? They're like this. Yeah. So frontal temporal dementia is different. It's actually one I like it because it's very rare and it's more challenging at times. But also I think there's a lot of caregiver support that has to occur in that setting, just because of what it causes. But frontal temporal dementia is two different types of frontal temporal dementia. The biggest thing that differentiate between frontal temporal and Alzheimer's is a lot of times with frontal temporal dementia, the memory is good. Their memory is impeccable. They're like, ain't nothing wrong with my memory. My memory better than yours. But the issue with frontal temporal dementia, excuse me, and while it is considered a dementia, is because dementia is a change in memory and or thinking, including personality, behaviors that impact their function. So a lot of people with frontal temporal dementia can have a normal memory, but something prevents them from being functional. The two different types is there's a semantic type, which is the type that Bruce Willis has. So all of a sudden they can't speak. So language is gone. So they just can't communicate. And they can talk as and you think you know they're talking about. They like garbled speech. They just can't. You can't do anything. And then there's a semantic type, that's language, and there's a behavioral type, which is the I was gonna say the craziest type, but I'm sorry. The most difficult type to manage. I'm sorry, I should have said that. But the most difficult type to manage because one, it impacts younger populations, mostly men, and their behaviors are so aggressive that it leads to institutionalization very quickly. Because it's like a different person. It's like a light switch, like something flips in the frontal lobe. And that's why we call it frontal temporal. So this is your frontal lobe of your brain. The frontal lobe is where our personality is. Okay. So that's where it's been your whole life. And just imagine something changes there. And you like, I don't even know this person no more. But it's like it's very bad. I can give you an example because they can get fixated, they have changes in their personality. You know, I had a patient one time that had been a star employee, no problems, never missed work, didn't have any problems with anybody at work, and then all of a sudden, over like a 1 year period, was having difficult relationships with coworkers, spending money like differently, like not taking care of home, and it was just like a different person. And the family had been kind of shopped around from different providers because it was like something going on here, but his memory fine, like he's still doing things. It's just that I don't know this person. Like this is a completely different person. So we got a picture of his brain and he had changes in his frontal lobe, just like significant changes. It was like not functioning. And so we were able to diagnose frontal temporal dementia, right? And then the behavioral part can be personality, but it can also be very aggressive. So they can be physically aggressive, and they can get fixated on things. I'm familiar with a case for a patient that was fixated on the Toyota Prius. You guys know what the Toyota Prius is, right? So they got fixated on a Toyota Prius and went to a local dealership, this was like a couple years ago, of a Toyota dealership and literally burst out every window of the Toyota Prius like just fixated on I want this car and no one will let me have it. So that just shows the type of change. And they say this man was like the nicest person you would ever meet. And he just literally had a change in his personality. So as you can see, dementia can impact a lot of different things, right? It can impact memory, mood, behaviors, recognition of family members, personality, all this things, right? So as I'm talking about this group and this family of conditions, all called dementia. Again, Alzheimer's is big brother. Second most common will probably be Lewy body and Parkinson's, but we're seeing a lot of vascular dementia after strokes. Frontal temporal dementia is the one that impacts men most commonly and can be younger populations. Mixed, this basically means they have symptoms from one or two. So they can have some Alzheimer's symptoms and then they had a stroke. So things they decline faster. So we would probably say they have mixed dementia because it's a mixture of both types of symptoms. All right. So when we think of, so I went through the different types of dementia. I went through the staging of dementia. Now as far as difficulty working and partnering with the patient, because I always encourage people, it's important to, as much as possible, include the patient in their care. That's why it's important to talk about it early. Because we as the healthcare community, we want the patient to be an active participant in decisions for them as things change over time. So if we push it under the rug and delay the conversation, then we are unable to capture their voice and what they will want done. Because that's where decisions need to be made toward the end of life. What would they want to be done? Would they want to do, would they want to be on the breathing tube? Would they want to do have CPR done on them? If we don't talk about it early enough, we're not able to capture mom's voice. Like, this is what mom would want. And then it puts more stress on you because you're like, well, I know what I would want, but I don't know what mom would want. And I want something different than my brother because he stayed at the house and he wants her to stay there the rest of her life, but I think she needs more support. And so if you're able to have a conversation that includes mom earlier in the process, then you can document what mom wants, so it's no stress on you as the daughter, the son, the cousin. Does that make sense?
Yes.
All right, because the family that works together to take care of patient at the beginning is more stressed and frustrated and mad at each other toward the end. And so when it comes down to,
The family that doesn't work together.
no, the family that hasn't captured mom and dad's voice at the beginning, because toward the end, you start coming up with your own ideas of what you want what you want from mom. But if we didn't allow mom to participate in that conversation, then it's more frustration between siblings, cousins, and all this stuff, you know? So I want you to work together the whole time, but at the end of the day, I want us to respect and honor what mom would want for herself. Because when we try to inject ourselves, because I do more for mom than you ever did. And you,
Shut up, boy.
y'all know how I can do. Y'all know how I can do, right? But that's why it's important to have the conversation. That's why I encourage people to talk about this early. Because if you want mom to be able to say, oh no, this is what I want. Or I want y'all, I've always been worried about this person. I want to make sure they're taken care of. Let's make sure we can honor her wishes. His or her. All right. And the reason why when we're talking about dementia, we often say her being the patient, because most patients with dementia are women. Okay. But that's not a comment on a battle of the sexes. That doesn't mean that men are stronger. In fact, it means that women live longer. And the greatest risk factor for developing dementia is actually age. So we have more cases of women with dementia because they live longer. So maybe it is a comment on the battle of sexes.
They done took care of everybody.
But that's the reason why I often say mom. So talked about the diagnosis. We talked about the types of dementia, talked about staging. Let's talk about behaviors. Okay. So I always tell families what brings the patient and family to the clinic is often memory loss. So we have memory loss, we do the evaluation, we're able to hang our hat and explain, this is why mom and dad are having these challenges, it's dementia. Okay, so then you walk away and you're like, okay, so if the doctor say dad doesn't need to drive, he needs help with his bills and he needs help with his medications, I can take that on. Like I can do it, I can just set up everything up on auto pay, everything be straight. But what keeps the patient coming back to the clinic is the behaviors. So that's what you can't do.
Yes.
Like I can even get down and help dad get dressed or help him bathing and things of that nature, but I can't take that he sees somebody in the room tonight, or I can't take that he's mad at me because he can't drive me, or I can't take that he's trying to leave the house. So that's what keeps you coming back to the clinic, because you need assistance. Okay. And it's situations and caregiver groups like this that help us get the word out of how do you navigate those challenges. Because it's more than just I can pay the bills, I can do the medications. It's, this person not sleeping at night. So I gotta stay up all night. So then I'm trying to go to work, but I can't go to work because I ain't sleep last night. So it's sort of balancing all that. So the different types of behaviors. And so there are behaviors that we see, and then there are psychological disturbances. So the behaviors is like agitation, aggression, and aggression can be verbal or physical. So they can be calling you everything but a child of God. And they can be physical doesn't always mean I put my hands on you. It can be I'm slamming the door, I'm throwing the pillow, I'm doing something that's transferring this energy I have, and it's more than just you don't like me, or I'm your mama, you ain't my mama, all that type of stuff. It's more than the verbal. So that's what physical is. And we actually see those steps before it becomes physical, where I'm grabbing you. So we'll see they're slamming the door, they're hitting their head on the table, hitting their hand on the table. We see that before. It helps us kind of predict where we are with that. So those are the behaviors. So agitation, aggression, wandering is a behavior. So trying to leave the house, and often I'll have patients and families will say, "Oh, Dr. Carrol, I ain't got to worry about mama leaving the house because like she always wants to stay in the house. She always wants to keep the door locked." But as the disease progresses, remember that this disease is sort of eating at their brain. Okay, just think about it like that, eating at the brain. So one day, this person has always wanted to stay at home and just, watch Judge Judy or whatever every day. They think, you know what? I gotta go get bread for today. That's what we used to do growing up. So I'm gonna get up and I'm gonna walk to the store. But I was going to Alabama, so the store was down the street. So I'm just gonna walk out this door right here, make a left. That's what I would do back home, and I would walk to the store. So they are being guided, by other memories and thoughts to go wandering. So they're going places that, and they think they know what's going on, but they don't. Or, one thing that people often do, patients used to always walk to what is it called? Walk to get their cigarettes in the morning. They stopped smoking 20 years ago. All of a sudden, I'm gonna give it a cigarette. Like, no more. So just think about that. Think about how that. Now, how do we manage some of these behaviors? So, so that's the behaviors, so wandering. Psychological disturbances is like hallucinations, delusions, and paranoia. Does anybody know the difference between hallucinations and delusions?
No, it's not. Here.
Okay.
You can come.
We all in this together. So hallucinations, they include one of the senses. So you hear things, you see things, you feel things, you taste things. So those are hallucinations, all right? So I see the little child over there. I hear my grandmother's voice. Those are hallucinations. Delusions are beliefs that don't involve the senses at all. Okay? So they're like, I'm in a relationship with some celebrity. I have a patient that has frontotemporal dementia. Again, they have different things. So they're in a relationship with this celebrity, and so they're sending the celebrity's manager money for security every week. This is the active case. So they have these fixed beliefs that don't involve a sense. They've never seen this celebrity before, but they are in a relationship with them. Or I know you took my money. Give it back to me. I know you took my money. So it's like a belief that doesn't involve the senses, and you can't convince them otherwise. Oh, I know it, I'm married to this person, all kind of stuff. So it's a fixed belief. So that's a delusion. And paranoia is thinking things that are happening, think someone is in a closet. So thinking someone in the closet is actually a delusion, but it makes them paranoid.
Right.
And so we can process or hear these changes. We don't always have to act on managing them though. So just because a patient has a delusion or hallucination, we don't necessarily have to treat it. If we're able to kind of cope with it, and sometimes it's easier to accept the hallucination or delusion, as long as it doesn't impact their safety.
Right.
So if they think it's a little girl in the room with them, as long as they happy with the little girl in there, you should be happy too, right? Don't worry about it. But if they are afraid of the little girl, if they think the little girl is going to take their food, if they think if the little girl is keeping them up at night so they can't sleep, or if the little girl is or if there's a woman in the room and she's trying to sleep with the husband, like all this kind of stuff. So if it starts to impact their safety and they feel like they have to defend themselves, then we need to address it. We do need to treat it. Now, sometimes that can be very disheartening for families because they want to go to the doctor for help. And they're like, Dr. Carrol, I know it's not a little girl in the room, my grandmother. You gotta stop her from saying that. Right? That's because it's frustrating with us, but that's the reason why it's important for us to talk about what the disease is and how it impacts them. Because if we don't know what's going on, then we will think it's a quick fix to everything, when it's not. Okay. I had a patient one time that literally the grandmother would sit in a rocking chair with her friend and knit the whole day. But the friend was a mirror image of her. And the daughter could not stand it. She was like, you gotta stop my mother from doing this. But the lady was happy. She was just knitting and she talking to the lady and things like that. And I know that's sad. I see you like, I get it, but you have to realize that at a certain point, she's comforted. She's comforted by it. So why we want to give her a medication that can potentially have side effects and kind of harm her, just so that she doesn't see it. And keep in mind, these medications, they may work, but because this is a progressive condition, that the medication that worked the first 3 months may not work after that because of the disease getting worse. So if she's happy spending time with her friend, that'll be happy. Because I would want to be out there too. If I felt stressed, like I'm just sitting with my friend and we making this knit thing, right? So just think about it. So that helps us. I say that to say not every symptom needs a medication. Because every medication can have side effects. But yes, if changing them, thinking a little differently about mirrors. I also have patients that will punch the mirror in the bathroom because this person is watching them get undressed. So again, they're having a delusion, or they see this paranoia about this person that's in the mirror that's really them, and they're doing everything that they're doing. So they're frustrated with that person and they want to hit that person. So yes, we would use medications in that. But someone who sees themselves in the mirror and they're happy because they're getting dressed and they're making the bed up, leave it alone. Leave it be, right? All right. So medications that can be used. So let's talk about medications for dementia. So there are a lot of different medications that are approved for dementia. There are some that have been around for years, decades, right? There are pills. There are some for mild dementia. And there are some for moderate and severe dementia. The medications are not the cure. I want to say that again. There is no cure.
Say it.
The medications are not the cure. Okay. But we can use them because they appear to slow the process down. Now, when they say they appear to slow the process down, technically what they mean is when we're testing the patient on where their memory is, their scores decline at a slower rate. Okay, so we may not appreciate it and feel it at home, but their scores appear to decline at a slower rate than what we would expect, right? So sometimes people say, well, if this isn't a cure, why am I going to take it? Because it does appear to slow it down at least a little bit. It doesn't stop it, it doesn't reverse it, but it tries to slow it down. So there are medications that have been down for a while. In 2021, a new group of medications came out that are infusions. So you get them infused into your veins. So you go into the hospital and you get an IV for these newer medications that are given. They variations. Some of them are given twice a month. But you go into the hospital and these medications do slow the process down more than the pills. I'm gonna be honest with you. The medications appear to slow the process down more than the pills. The issue that I have and the issue that the majority of my colleagues have with the medications is the side effect profile is more concerning than the pills. Okay. Now, how much does it slow it down? The data suggests that the infusions, the one that's most commonly used, slows down the decline about 18 months. Now, some people say that, right? But 18 months can be a lot. If it slows it down, it can help us as a family get better prepared for the decline. It can help that person be able to participate in their granddaughter's wedding. So that can be a lot, and it can mean a lot to people, right? But the potential side effects includes brain swelling and brain bleeding. To me, that's not worth it. That's to me, though, right? And I wouldn't advise it to my mom. It'll be up to her because I want her to have the decision. That's why we got to talk to her, right? But I would recommend it for my father. But some people are doing it. Okay, so it does appear to slow it down. The thing that you have to keep in mind though, that medication is approved for Alzheimer's only. So if your family member has a different type of dementia, Lewy body, Parkinson's, frontal temporal mix, they won't qualify for that. Okay. And you may say, well, why does anybody do anything for Lewy body or Parkinson's or mix? The reason why is because the majority of the research, the majority of the funding and all that stuff is on what's impacting the majority of the people. Because remember, 70% of people with dementia has Alzheimer's. Okay, so if we want to create change quickly in medicine, if we come up with a cure for Alzheimer's, it's gonna be a game changer.
Praise the Lord.
Okay, it's definitely gonna be a game changer. But that's the reason why. It's not that the healthcare community doesn't care about the other forms of dementia. It's just when it comes to the dollars and cents, the country, the federal government, they're gonna pour money into what's gonna be impacting patients.
Well,
Okay, so keep that in mind. But the best thing that we have now to manage dementia itself is the environment. So knowing what the patient still can do, what they can't do, assuming responsibility of those tasks, and allowing them to do everything they can on their own for as long as they can. And that's the best way to do it for me, is because that's the only way you'll know that things are changing. Because you'll know that, I had to do the cooking, the cleaning, all that stuff. But then now dad isn't as attentive to his personal care, so I probably need to start going to the bathroom with him. But if you come in and say, oh, you know what, Dr. Carrol said you had dementia, so starting tomorrow, I'm doing everything for you. I'm paying you, I'm dressing you. You won't know what's changing over time. And it's gonna cause more stress with the patient.
Yes.
Because they're gonna be like, I'm gonna do this. So you'll see that being more of an issue. All right. I'm trying to think of something else. More of the behaviors. So behaviors can be a variety of behaviors. It can be, not thinking that they're home, like thinking they need to go home. And often they're thinking of their first home when they were born, or they may tell you that they stay at the address that they were born at. And you're like, Mom, I don't even know what the address is. And that may be the first address that they remember. I want you to think of it as, as you grow up from a child, you learn things in a certain format. So the first thing you do, you learn how to turn over. Then, you're turning over, you're crawling, then you're walking, and then you learn how to take care of your personal care needs. And then as you get older, a teenager, you might start paying some bills for yourself to get a job, things like that. When you think of dementia in this condition, everything happens in the reverse. So you start losing how to pay the bills or losing how to drive. That's what you were excited to do when you were 16 or 17. That's what you first start having problems with when you have dementia. And then you lose things as things progress. And why do I bring that up? Is because when we think of how things change over your life. As I mentioned, some of the first things you do, you're excited when your child turns over by themselves, right? One of the things we worry about with patients with dementia, when they're bedbound, their brain does not tell them they need to turn over. So they develop bed sores.
Yes.
Okay. When we're in the bed at night, our brain tells us, okay, now, been on this side about 20 minutes. You need to turn over. But they lose that signal. And so they literally, where you put them when you put them in the bed, that's where they're going to be till you go back in there to turn them over, right? And that's how you can get bed sores. So when your child starts to do that, that's their brain starting to send them signals. It's time to turn over. Because if you lay on one side too long, your skin starts to get impacted, right? All right. So think about dementia like that. And that's how it can impact you. When at the beginning it's mostly memory, but at the end it's like, just think of it as a signal that your brain sends to different parts of your body, whether it's coordinating your walking or knowing to turn over. Okay. That's all I have.
yes.
Test. Oh, okay. That's great. So dementia diagnosis is a clinical diagnosis, right? So you may have heard that we can see dementia on imaging. There are some very expensive type of imaging where we can see changes that we expect with dementia, but it's a clinical diagnosis. So it's a collaboration or it's consideration of a lot of different things. So one is history. That's the actually important part because we want to be able to get the history of what has changed for this patient over time. What were they able to do 10 years ago that now they can't, or 3 years ago that now they can't? So history is important. We do some testing. There are a lot of different tests that are out there. A lot of these tests are screening tools. Again, they are not the fix-all for diagnosing dementia. If you go and take the test with your doctor and they tell you, oh, the score is out of 30, most commonly the different tests that we use out of 30, and they say if it's less than 23, you have dementia. Don't let them tell you that. Okay. You have to consider a lot of different tabs because some people, one, may not test well. There may be other reasons why the score can be on a lower end. So you have to consider a lot of different factors. You could have been nervous, you could have been stressed, things of that nature. And we're able to sort of tease out, do we think the person was, anxious or nervous? Like, could that be a component, or is this likely where they are, right? Sometimes patients will tell me, oh, I didn't do well on the test because I wasn't prepared for a test. When I came to the doctor, I know. And so I'm able to take all that in and say, okay, there might be something more here, because the things I'm asking you aren't necessarily something that you really have to study for. Okay. But if they feel as if they need to be defensive, and a lot of times a lot of patients are very defensive because they see me as trying to attack their level of independence. Right? And I get that. And so, but we use that as a way to sort of see where the person is, but we take into account other factors as well. So what the patient's family is reporting, what we're seeing, how are they dressed, or even how they've been able to navigate the healthcare community the last 10 years versus now. What do I mean by that? So this person was always on top of their medications. And I look at the chart now and they haven't refilled their blood pressure medication in a year, but they're telling me they're taking it. Okay. So I know for a fact, and this is primarily at Kaiser because we're a closed system. So I know where you get your refills from. So you ain't getting it from Walgreens. You ain't getting it, right? And so that's one of our perks because we're able to see, oh no, you've been getting this refill like every 3 months for the last 10 years. And you taking it now? They're like, yeah, I'm taking it now. I'm like, well, you haven't refilled this since September of 2024. So I don't think you're taking it. I'm not saying you ain't taking it this morning because you might have said, I'm taking it for a week. I don't think you've been taking it every day since September. So that's how we see, or we see that they've been on top of all their screenings or going to the doctor all the time, and then now they're not, like they're just not engaging that way. And so we use those changes in behaviors to sort of see if things have changed as well. And so it's a clinical diagnosis. There are tests that we can do that look at memory, thinking, naming, orientation, all those things, and that help us guide what we think is going on. Okay. Imaging. So different forms of imaging, as I mentioned, there are some very expensive tests where we can look and see, okay, this is changing and we see this in dementia. But Alzheimer's in general is the diagnosis that the only way you can definitively diagnose it is post-mortem. So with an autopsy. So everything we do, it's not magic. It's that it's probably this form of dementia. Because the only way we're able to say they definitely had dementia is if they pass away, we do the autopsy and we see the tangles and stuff in their brain. I don't think we necessarily have to go through that. But I'm happy that some people did, commit themselves to science so that we can learn that information. But what we do a lot, particularly in imaging, is we have images of those people that did get an autopsy. And so we know what their brain looked like. And so we're able to compare their brain to what your brain may look like. And we say, this is most likely how this looks. Okay, so we have to appreciate the advancement in science and sort of understanding how we can determine that. So there are different types of imaging. Structural imaging, you just want to see what's there. You want to see if they've had a stroke. You want to see if they have a tumor. You want to see if they have a brain bleed. So that's like a CT scan and an MRI. Structures.
With a CT scan, because mom had calcification of the brain. And so they kind of deduced it with that, and her behavior changes.
Right.
Like when she wore them black gloves up to here to church, and the way she was dressed. I mean, we knew things were changing, they weren't the same, but I'm just saying, the CT scan was when Dr. Lyons said she's got calcification of the brain.
Right, so that's a great example because those calcifications of brain, we do see those in aging, right? Now, but the thing that became the slam dunk for the diagnosis was a change in behaviors, and that's clinically how mom presents because it's possible that my CT scan has calcifications. So that's just what the picture, that's what the brain looks like. But clinically, how is this patient presenting? Like they're still able to do everything. So I can get an MRI. I mean, just like you can get a CT scan today that show that you have a stroke. You didn't know it. There are small strokes that are occurring, but clinically, you don't have the symptoms. So you won't say, oh, this person had a stroke.
Right.
Okay. But so clinically, how is this person presenting? So clinically, they're not the person they used to be. They're not paying their bills. Clinically, there's changes in their behaviors. And so you're saying clinically this patient has dementia. But imaging is not the only, that's not the way you diagnose it. It's imaging plus other things, right? So CT scan, MRI. The different types of imaging, so structures, looking at what's there, CT and MRI. Looking at how it works is like a PET scan. So you may have heard of PET scans.
Yes.
And so that's not only looking at what's there, it's looking at how what is there is doing. Okay. Now, have you guys ever heard of PET scans for cancer?
Yes.
Yes.
Okay. So PET scans for cancer, we use that same technology. So what it is when they're looking for cancer, the cancer cells are rapidly dividing because cancer is growing, right? And so when they take a picture of you with a PET scan, the way they're able to say this is where we think the cancer is because they're able to look and see how bright the colors are there because the cells are working so fast, right? So they're able to do a PET scan and say this person likely has breast cancer because her left breast is very bright.
Yes.
Okay, so that's a PET scan. We use that same technology for dementia, but we're looking for the opposite. So we're scanning their brain, which is always working, even when you sleep. And we're seeing that their brain is dark. So there's certain parts of the brain that the cells are not working as fast that we would think it is. Because when you do a PET scan, that brain will be working. That person's still, they're not doing nothing, but their brain is thinking about what I gotta do when I got this. I gotta put this tonight. Go do this person. I gotta get ready for church and all this. So your brain is constantly working. So when we do the PET scan of the brain, there are certain parts of the brain that aren't working as well. PET scan is very common with frontal temporal dementia, the one that Bruce Willis has, because we see this frontal lobe and it's just not working. It's just not, they call it like dancing in the imaging. So it's just so bright, like, oh, this person's doing a lot of stuff here, and it's just not working, right? So different forms of imaging that can be done. And so when you think of these new ways to treat and manage dementia, a lot of them involve imaging. And so that's also going to be an issue as the management of the condition progresses, because when you think of these expensive forms of imaging, you worry about access. At least I do. Like, who will have access to these forms of imaging?
Yeah.
Like, will certain communities not be able to access these forms of imaging? And so we won't really be able to track what their dementia looks like. And so we have to rely on CT scans and MRI. CTs are everywhere. You get a CT on the corner, right? But when you think of these very expensive forms of imaging that are coming out, I appreciate them because what they can do, but I don't know how accessible they will be to the general population. Right? So you have to keep that in
I
mind.
wanted to ask you a question about that in terms of the infusions, because that's quite expensive, correct?
So
Like how much?
So there's still ongoing conversations about what Medicare will cover and if your insurance will cover it, and like all that stuff is going on. But it's in the thousands. I think it's 20-something thousand
That's what
dollars.
I had heard, around 25,000.
I think it's 20-something thousand injection, but sometimes it's covered, and that could be an access issue as well.
That's what I'm saying, yeah.
That could be an access issue as well. So, but the hope is that eventually Medicare will, or some form of insurance will cover it, but that's access too. So it's a lot of different things that are at play there. So what I'm telling everyone to do is, until there's a cure that's available for everyone, and we know it doesn't have these really bad potential side effects, then the best thing to do is environment, diet, exercise, and providing support for the patient, right? Difficult decisions that need to happen along the way, and I'll open up for questions after this. I'm doing okay with time. Okay. Difficult decisions that need to happen along the way. Sometimes there are three difficult decisions that we see in managing patients with dementia when I'm partnering with the patient and the family. The first is driving. So having a conversation about driving is very difficult for this patient because they definitely see that as an attack on their level of independence.
Right.
Because you can't tell me that I can't go get in my car. It's got to happen. I'm going to get in my car right now. Like, I'm going to do that right now. So I'm doing it. So, and why do we have to report it? Why do we have to report it? Now, let me be very clear. Within the state of California, we are required, physicians are required to report the diagnosis of dementia. Okay? Families don't like me because of that.
Yeah.
No, patients don't like me first. But families don't like, I mean, lawsuits and all that kind of stuff, but we're required to report them because it's a safety issue.
Yeah.
Okay, we know that grandmother doesn't do anything but go to the grocery store on Tuesdays, and we know that she goes to the church on Wednesday and Sunday, and we want her to still be able to do those things, but it's not safe for her to do it because accidents occur going to the grocery store and going to the church. And if as the dementia progresses, her going to midweek worship on Wednesday and it's 6 o'clock and it's getting dark, she missed one turn because her memory has changed.
Right.
She ends up in San Francisco.
Right.
And so just keeping that in mind, right? And so we're required to report. So we're required to advise on the risk associated with driving and report to the DMV. Then the patient, if they would like to continue driving, they have to complete a safety evaluation. That forms have to be completed by them as well as their provider that reporting them. And they have to complete that process. As long as I report it, it's at that point out of my hands. Not that I have anything to do with it, but I have to advise the patient and the family that I have to report it. And it's nothing we can do about it. Okay. That's a requirement in the state of California if something happens. So difficult conversations is driving. The second one is what?
Money.
You know that, right? So you telling me I can't drive. But Dr. Carrol, on the last visit, he told me I can't drive. This visit, he's saying I can't manage my money, right? And that's another thing that's linked to your independence. Because we all want to be able to spend our own money, right?
Definitely.
Because it's ours. Okay. And so, that's a difficult conversation because often when you're having that conversations, the patient doesn't want to hear or they don't understand it. And at what part of when I talk about the staging, what part is money impacted? Their ability to manage their money.
At the moderate,
I mean, the one before that.
the one before,
Right. So remember, mild is hands-off care.
Right.
So it's stuff that don't involve their personal being.
Right.
So it's paying their bills, doing their medications, doing the cooking, the cleaning, the driving, and all that type of stuff. That doesn't involve their personal self, right? So, and during the mild stages, sometimes the patient don't even know they're
Exactly.
They really want to fight.
Yeah.
They're like, I don't go nowhere with your store. Right. So that's a different conversation to have with driving and managing money because they still feel like they can do it. Now, what could be happening with their money? A couple different things. One, they could be not paying. One, they could be paying but paying late fees. So we think, oh, we can take care of all the business. You get them bills, she's been paying a $30 late fee the last 2 years. Just because she's paying it late. And the LADWB don't care. It's like, it's $30. We'll take it. So that's why it's important to kind of take a look at those things. And the last potential difficult conversation, and it's the most difficult. So we talked about driving. Money. What's the most difficult conversation you have with patients and families? Staying home. Staying home. Okay. So told me I can't drive. So I gotta stay in the house, right? Now you tell me I can't take my bill. I can't pay Spectrum. Now you telling me I can't stay home. Okay. Now, that's a difficult conversation, not only just for the patient, but the family, right? Because we have these thoughts of, I want mom and dad to pass away at home, this is their home, this is what they put all their lives in. I get that, and I want them to stay at home too. Actually, the data supports that people do best at home. We call it aging in place. Okay, that's the thing, aging in place. However, if the patient's care needs exceed that which you can provide at home,
Right.
we gotta make some changes.
Yes, yes.
If it is draining you, if it's killing you, and you can't do it anymore, we gotta think of other options. Now, I know some of us are wed to the thought that I will never place my mama, my daddy. I get it, and I respect it. I understand that wholeheartedly, but it can be a very difficult commitment. And a lot of times there are a lot of psychological motivations for that because the data actually supports that a lot of people feel like I don't want to place mom and dad because I don't want my kids to place me. Okay, but you are running a risk of that person, your loved one, not getting the care that they need because you say, I need to do it all by myself, but this is what I want to do. And I understand that. So when we make these agreements with our family members, our moms and dads, and it's a difficult conversation. So I don't want anybody to think I'm stepping on their feet. But when we make these agreements with mom and dad, we're making it with them when they're 55, 56. They fine. They drive it to get in clean. It's like, oh my, that place you.
Right.
Like, you ain't like the lady in the church, like good. But we're talking about somebody who is 77, 80, can't take care of their personal care needs, can't take, wandering, they're walking away, or they can't take care of themselves. So we gotta have these difficult conversations. And sometimes it's easier to place them. When we say place, a lot of people say, oh, we've thrown them away, Dr. Carrol, you don't want them to be taken care of. No, I'm saying sometimes placement is best, it's better for you and them.
It is.
They thrive sometimes.
Yes.
Like it can be a very difficult conversation to have, but sometimes we have to have it.
Yes.
We have to have it. And so we're there to sort of help guide you guys through it. Now, a lot of times psychologically people feel like I don't want to take mom out of her home because, I want her to pass away here. And I know if I place her, she'll never come back home. So psychologically that can impact us too. Like she'll never be back in her home. But you have to worry about the impact they can have on you. So I've also seen caregivers lose themselves and care of others.
Yes.
That's right.
That is so.
So I've seen caregivers have a stroke or a heart attack, and then both of them got to be placed.
Yes, yes.
Because the kid's like, oh, we can't do this.
Yes, we do.
We can't. So mom and dad got to be placed. And so it's easier, even if you don't plan or don't want to place mom and dad, which I respect and I want them to stay at home as long as possible. We need to have a plan in case it gets there.
Yes.
Because we don't want the first conversation about that to occur in a traumatic situation. They failed, they broke their hip, now they're in the hospital.
Yeah.
And now we gotta decide within 3 days, because the case manager like, y'all gotta get out of the hospital.
Yeah.
So you wanna be able to have conversations, they wanna have conversations beforehand about what types of things we would want to do.
Yes.
You wanna participate in, okay? All right, so I think that was pretty much a lot,
But it was good.
Yeah.
And so any questions about dementia? And again, my responses will be very general because I haven't seen anyone's chart, so I can't comment on if it's this type of dementia or that type of dementia. I'm not going to be in conflict with any of my colleagues. But I'll make some general comments. I'm definitely here as a resource for each of you. So just let me know if you have any questions.
Great, thank you. So I would ask, because I'm sure everybody has questions, let's probably use our hands, same thing online, and I'll just volley back and forth between in person and online. So, yes, I'm gonna go with this gentleman first. Lynn?
Doc, is the basic cause of dementia inflammation of the brain and if not, what is the basic cause? Hereditary or what?
Okay, so that's a great question. So the general belief about what's happening with dementia, and as you may have mentioned, you may remember when I said that the only way we're able to definitively diagnose it is post-mortem. So they pass away when we do autopsy. So when we do the autopsy, we're able to see these tangles, like tangles that are in the brain. So what our general thought process is, what happens is it's a problem with folding of your protein. So just imagine your memories being folded. Okay. I want you to think of like a suitcase. So think of a suitcase, and that suitcase is your brain.
Dr. Carroll, they can't hear you.
Okay, sorry.
That speaker.
All right. So I want you to think of it as a suitcase. So your suitcase is that brain, right? So throughout life, you're packing to go on a trip. You're able to fold everything very tightly in your brain. So your suitcase is folded. You got your clothes, you got your clothes you're going out with, you got your clothes for a nice dinner, you got everything folded perfectly and organized. What happens with dementia is the thing in your brain that's responsible for doing the folding of the clothes, it gets disrupted somehow. So you're unable to fold the clothes as tightly. And so when you try to fold the clothes in your brain, these are memories that you're making. They can't be folded correctly. And so they start backing up in the brain. Because when you're putting clothes, when you get putting things in the suitcase, everything is so tightly closed. You got your shirts are tightly folded. You got all the air out and everything. So it's nice and flat. But when over time you start losing the ability to fold those different clothes, it just gets backed up. And so you can't close the suitcase anymore. And what happens, that's why you have problems with short-term memory first, because those are the things that are trying to be folded later. It's folded. But the things that's been there for 50, 60 years, it's folded. This is nicely, and you're able to say, well, I remember when I used to live on Percy Road, and I remember this, but they can't make new memories. And so what happens is over time, that unfolding that's occurring, or inability to fold, it starts to impact even the stuff that's folded correctly, because it's just building up on top of it. So think of it as a problem with folding your clothes in the suitcase, okay? And then over time, everything just starts to unfold.
You just throw them in the bag.
And then you just throw it in the bag. So you can't put it nowhere because there ain't nothing to put in there, right? And so it just sort of over time unfolds it. So the way that the medications work, the thing that prevents the things from folding correctly. So you have this shirt that needs to be folded. There's something that comes along, dementia, that prevents it from being folded. These medications try to target the thing that's preventing the problem from folding. It's trying to slow that down.
So we really don't officially know what that something is. It's preventing being folded.
That's what we're on the hunt to find. And once we find that, once we're able to reverse it, because it's not necessarily about finding the fountain of youth, but it's about preventing the impact of the decline. That's it.
But billions and billions of dollars have been spent on research.
And they still haven't found it.
Well, as far as we know, it's like a lot of different things, like environmental causes, stress, this mix of genetics, family history.
Oh, you did
a
mention,
lot of.
I'm happy you brought up the genetics. So there are some familial forms, so that are through the genetics, right? So there are some genes that are associated with Alzheimer's, right? Those genes, when we see them, like you may be able to go to your doctor and say, oh, I want a genetic test for dementia. Can you do that? Because patients will come for us for that. So there are some genes that are associated with dementia. Doesn't mean you're going to get it. And so while in some cases you can get those ordered, it's sort of an issue, and from my standpoint, unethical to order it, because I can't counsel you on that. Because you're coming to me as a 25-year-old, 30-year-old saying, can you tell me if I got a gene for dementia? Because I need to know what's going on. But there's a chance that even if you have the gene, it won't express.
Right.
So you have the gene, but that doesn't necessarily mean you're going to get it. So if I'm ordering that test back to back, just to let people know if they got it, they are walking around like, oh, he told me I got a gene for dementia.
Right.
So then they're checking everything, and then they like, it's difficult to manage that information because you don't know if it's really going to express or not. So there are some genetic forms. The genetic forms are very rare. but they are out there. Okay. And the genetic forms, the penetrance of the genes, and that means how deeply it penetrates your family is really high. So when people have the genetic forms, they're able to walk in immediately and say, my mama and all her sisters had it. And I think my mama used to say my grandmother died early. She had problems with her memory, and something was wrong with her brothers and sisters too. So it impacts the entire family very deeply. The most common form of dementia is not the familiar type. It's the type that we get that's associated with aging. So remember when I was saying most patients with dementia are women because they live longer. The greatest risk factor is not your genes, it's your age.
Yes.
Thank you for mentioning that.
Margaret, I saw your hand, or actually it was a clap, but I'm not sure if you were trying to raise your hand online. Margaret, did you have a question?
I'll take the class too.
Thank you so much, Dr. Jarrod.
No
That
problem.
is so wonderful. I don't have any questions. All I have is praise. Great job.
No problem. We're here to help, okay?
Yeah, I'm doing research on spouse caregivers, and I'll soon be reaching out to anyone who wants to participate so I can interview them and give a voice to their experience.
Okay. What I would say about spousal caregivers, so spouses care of the families. But I encourage spouses to also be open and honest with the physicians as well and explain what's going on at home. What we see with spousal caregivers, sometimes, this is a generalization, sometimes they will underreport the changes primarily because they say, oh, I do the same thing. And and that's often a comment on your independence as well, because you're like, I don't want nobody to know that's going on in this house, so we go keep this, let's be whole type thing. So it's important to be open and honest with what's going on with your spouse, because we need to be able to talk about it. And it's best for you to tell me what's going on so I can tell you, oh, that's normal, that's fine. Because we expect some changes in memory, that's normal. But if you don't tell me about anything that you're saying, then I won't know, I can't referee or determine what's normal, what's abnormal, because you're telling me everything fine. Okay? All right, so, and then it's the opposite with adult children. So adult children were over-reported. And they were like, oh, I know what's going on. Again, over-report, but in over-reporting, able to referee and say that's normal. You've never seen your mom 80 years old, so this is not wrong for her. So spouses will underreport. They want everybody to know this home's so tight. We got this together. And sometimes adult children will over-report. So, but the key is just reporting and helping, allowing the doctor to sort of referee what's what.
I'm not sure if this is limited. So a person that is at the severe level of dementia, is there such thing taking them off the medication that was prescribed for them for dementia?
Yes, so the medications can be discontinued in a variety of ways. So one, if we don't see there's any clinical benefit, if we don't think that it's helping them anymore, then it's important for us to stop it. Right. Or if they're experiencing side effects, because again, it's not the cure. If it was a cure, I would say, well, it's not the cure. So if they're having problems with it, or if we don't see any clinical benefit, or if the patient's starting to have problems swallowing, so why are we continuing to try to give them this medication and we run the risk of the medication going to the lungs, if they get the stomach? We should go ahead and stop it. Now, there's some debate on if the medications can be abruptly stopped, like you take it today and don't take it tomorrow, or versus maybe to be tapered off. There trains of schools have thought about that. It's been on how long they've been on it and which ones they're on and kind of things like that. But yeah, they can be taken off of it. Again, I always focus on what's the reason for the dementia, if it's vascular dementia or if it's a different form of dementia. Often it's not really the dementia medications that's the major thing they need to be on. For dementia, I want us to prevent another stroke from occurring. So I need to make sure their blood pressure control. I need to make sure their cholesterol is controlled because I want to do that first before we talk about doing something. But yeah, they can.
And that's my situation. He has vascular,
Okay.
dementia, and I don't see the medication that, and he does need, because he has stroke, so he does need the Plavix and the aspirin.
So that's more important. So one of the things I do, I will prioritize the medication. So I'll look at our list of medications and I'm like, of all these medications, this is what I definitely need them to take because I don't want another stroke to occur to cause me rapid decline. So that's deprioritize these memory medications, not as important right now.
You know what, to add to what she just said, like I said, my mom was diagnosed 6 months to live. And all my brothers came to sign the papers. And the medication was just exacerbating her condition. I took her off of mainly that morphine and put her on all herbs and natural stuff, changed her diet. And she ended up living 10 years. They had given her 6 months. So that medication was everybody. That medication was doing a number of them.
Yeah, and I think that highlights the fact that, we can't give the same prescription to every patient and every family. And so everyone is different. And so you have to see where you are and see what you think is benefiting them. So if it was impacting her and hurting her more than helping her, that was the right thing to do. So that was the right thing.
Thank you.
Next, I want to call on Deborah.
Hi, thank you so much, Dr.
Uh-oh, hold
Carrol.
on,
This
Deborah,
has
we
been
can't hear you. 1
so
second.
helpful. This has really been helpful. What we're going through is our mother has not been officially diagnosed.
Yeah, my Zoom out,
However,
so she
she's
got
experiencing all of the symptoms.
Okay, go ahead, Deborah.
Can you hear me?
Yes.
Yes.
Okay. Our mother has not been officially diagnosed. However, she's experiencing all of the symptoms. Like, you took my money. She's hiding things from herself and then saying somebody took it or she can't find it. And she says someone stole it. And so she's going through all of those different symptoms. And so we are trying to determine how to get her to the doctor, because we did take her once. They did ask her some questions. She answered all the questions. What's your birthday? What's today? That kind of thing. However, she's still really pretty much in control of herself, except, she stays up all night, then she sleeps all day. She doesn't remember certain things. And then all of a sudden she remembers everything. And she's gotten, combative, with my sister. And so we're just trying to determine, how do we get her to the doctor when she's, able to say, I don't want to go to the doctor.
All right, so that's a great question. Thanks for asking, Deborah. So I would say it needs to be twofold. So are we able to communicate with her doctor at all?
Yes.
Okay, so I would reach out to her doctor and give him or her the information you described as far as changes in her behaviors, changes in her overall function, mood, and all those things. So that information is, they have that information the next time they see her. And then I would request, if you think it's time for her to see the doctor for her general health, I would request that the doctor and their staff reach out to schedule an appointment with her, because that still allows her to be in control, but they will have the information that you have provided to them to kind of color the situation when they come in and evaluate her. Because often when it happens in my space, I'm able to say, okay, we'll get this patient in, and we know that mom and dad has always been in control, so they will try to sort of command the attention of the room and run the visit, but you have this background that you're dealing with because you know that the daughter's reporting person isn't paying their bills, isn't taking their medications. And then as you're working with that patient, you're able to sort of identify some of them things by the assessment that you're doing, and then you're able to pull it all together.
Yes, because she has times when she gets really agitated and she gets angry and she wants to start, fighting with everyone. And then she's, quiet, or then she's starting to shuffle a lot when she's walking. We have to make sure because she's falling, that kind of thing. And so we try to keep. She's living with my sister now in Dallas, and so she's not in California here anymore, but she's in Dallas. And my sister is having really a hard time. She's becoming like the caregiver that's really struggling with.
Yeah, I know. I know the story very well, but I think the key there is trying to get her in to see the doctor and ruling out other potential causes. Because you mentioned that she's not sleeping, so poor sleep can cause people to present similarly. So ruling out other things that could be contributing to it. So we want the visit to be one where we're checking in with mom. So she does appear to still be in control. So what are the current issues? And then armed with the information you and your sister are able to provide, the physician should be able to sort of come up with a plan for next steps for further workup.
Okay. All right. Thank you so much. This has been very helpful. I've been taking notes, and we pretty much, have been looking up information. So we pretty much know what's happening in terms of, yes, this is what's going on, but we're not doctors. And so we're just kind of winging it as to what to do. And we don't want to put her in a home. We want her to stay with family, but it's getting tough.
No, I get it. I get it. And then you bring up a good point. When we think of, adult children that are getting involved, the patient stays with one of the adult children, and you worry about that caregiver stress on that person, and if that can strain the relationship between you and your sibling, all those things come to play. And so that's why it's important for us to try to at least figure out what's going on as soon as possible so we can come up with a plan of care.
Thank you. Thank you so much, Dr. Carrol.
No problem. We're here to help.
Sheila?
Okay, I have a question, Dr. Carrol. You talked about not really being able to diagnose dementia as a gentleman except for postpartum. Is that correct?
Postmortem.
Postmortem, when they die of autopsy. So you listed 3 things I wrote down. If you think somebody has Alzheimer's, because you can't diagnose them based on what you just said, right? So you listed environmental, diet, and exercise, but you didn't say what those things were.
Okay, so as far as diagnosing Alzheimer's, all cases are probable or most likely Alzheimer's or form of dementia. The only way we can say definitively that this is dementia is if we look at the brain and look at the tangles. But we can say this is how the person is acting, or this is clinically this is how they appear, right? And so as far as management, because you were talking about management, right? So
I was talking about 3 things you listed were environment, diet, and exercise. So you didn't say what type.
But that's typically what I say. That's the best way to manage it versus the medications. So the environment. So making sure it's one safe. Okay. Identifying what they're still able to do, allowing them to still be able to do that as much as possible within a safe environment. And what they can't do, we step in and do. Okay. Because if we still allow them to do what they can't do, that's going to be a stressor, which can cause them to decline at a faster rate. So they're still trying to manage the finances. So you go there and they're still trying to pay their taxes. You go there and dining room table is papers everywhere because they can't figure out how to do that. And so you want to limit the stressors because stressors can make people decline at a faster rate. That stressor can be personal stress, they can be worried about their grandkids, they can, all kind of stressors can cause you to decline, not just from a memory standpoint, just thinking in general, worrying about stuff. So environment, diet, what we eat, okay. The biggest thing that I see a lot, particularly as it relates to Alzheimer's and vascular, is like portion control, like how much we're eating. Because I can't come to you as somebody my age talking to somebody from 77 and say, you know what, I don't want you to eat this no more. You're not gonna listen to me. But we gotta partner together and say, I want you to monitor how much of it you're eating. Okay. We don't want you eating fried food every meal. So I want you to still enjoy what you enjoy, but we want to watch what we're eating and make sure we're not eating certain things that we know can be associated with raising your blood pressure, raising your cholesterol, raising the risk of diabetes.
Okay.
So that's like diet. Exercise is what we're doing. So walking, doing things around the house can be exercise as well, because you gotta keep in mind that helps your mind and your body, because it's, you're exercising your entire body. Sleep is important, because if you don't sleep, that can cloud your memory too. Because a lot of your short-term memory is stored during the part of your sleep cycle. So if you sleep well at night, then what you had from the short-term memory the day before is stored during that time.
Yeah.
So that's more so management. So, and I say that because I always say we think about management, because I don't want people to be so wed to medications, because it's not the cure. Because if you're very wed to the medication, then you're most likely to say, this isn't working. And I'm like, yeah, like, no, I want us to do other things besides that, can help.
Any other questions? Yes. What's your opinion on ataraxia?
Okay. So statins in general, so what you're commenting on is, so the group of medications that we have for cholesterol, they're called statins. There's some data and some conversation about it can be associated with memory loss and developing dementia. The data is mixed. I agree that statins should be used for preventing or trying to decrease the risk for strokes. The way that it became a conversation is people started reviewing a lot of cases and looking at the research, and they've determined that a lot of patients that have been diagnosed with dementia, you come in these.
Okay, I mean, our conversation was going on. You hear everybody tell?
You know I know you.
Yeah, how you doing?
All right, the data suggested that people with memory loss and with dementia, a lot of them seem to be on the statin. And so people started saying, I think it's the medication that's causing it. And there's some data that suggests that there's an association there, but there's no definitive data to say that it proves that there's a connection. Because it's correlation. So correlation, these two things happen at the same time, it doesn't mean causation. Okay. And so when patients and families ask me about, Dr. Carrol, I want to stop my statin because I saw that it caused dementia. That's why I'm having to see you because I'm taking a statin. I tell them, okay, we can talk about it. I think what I'm most worried about, I'm less worried about this and medication causing memory loss. I'm more worried about you stopping it and you having a stroke.
Yeah.
Because if you stop taking the medication, that could potentially increase your risk for stroke. So you're basically saying, I don't want to take it because it might cause some memory loss. But then you stop taking the medication that can decrease or decrease the risk, decrease the chance that we're able to clean out some of your blood vessels for that cholesterol. Because the statin, the medication is there to sort of decrease your buildup of cholesterol, which can clog your blood vessels. So the lesser of two evils. Yes, there's some data that suggests that it could be associated with some memory loss, but if you don't take it, you could have a stroke. So it's sort of which one you want to have. So in my opinion, I understand where you're coming from, but in my opinion, I recommend patients still take it and just monitoring the cholesterol and making sure that the statin is serving its purpose of lowering your cholesterol.
So what is the cholesterol? Because the last blood work that we had done, the cholesterol was extremely low, because I've been managing the diet now, so I've been on top of it. So the cholesterol was extremely low, and the doctor was still like, no, he takes it. Yeah.
Okay, so again, I don't know the whole story of the case, but there's some data to support that a patient was probably still need to be on a very low dose, so they could have at least decreased the dose. I'm not sure if they did or not. Just because that's the way that the medication works, it sort of keeps the cholesterol at bay. It's similar to there are some forms of diet controlled diabetes. Just making a connection here. So diet controlled diabetes, you can eventually not be on medications, but sometimes when people have had diabetes and then they were on metformin or one of the oral glycemic agents, and they've been on it for a while, but then their A1C, which tells us they have diabetes, is now normal. So then people be like, oh, I don't have diabetes no more. But it's really that medication that you can still be taking the low dose is kind of keeping it at bay. Okay, so you still technically have diabetes, it's just that it's so well controlled. So that's something to consider. I don't know how, I'm letting the Zoomologist control.
Yeah.
I want her to beat me up.
Hey, one more question in line and one more question in the room. Go ahead, please.
Doctor, I wanted to know what you're feeling about vitamins. I'm a vegetarian, so my mother was a junk food eater. However, I converted her. I get it. But yet I also Googled and looked up all types of vitamins to help.
Okay.
What's your opinion?
So just generally vitamins?
No. I went for memory, like your vitamin B3, your vitamin B12, fish oil,
So a lot of those supplements. So,
Yeah.
so supplements are okay. In fact, one of the reasons, and this may go back to what you were saying, what you were commenting on, Deborah. I think mom has the symptoms that make us worry about dementia, but we do need to evaluate for potential reversible causes because B12 can be associated with memory loss. So if your vitamin B12 is really, really low,
Right.
it can cause clouding in your memory where it can look like you have dementia. Okay. Now, there are some ways that we can sort of differentiate. Is this memory loss because of B12, or is this probably that they just got B12 deficiency and they got dementia? But it's important to sort of realize that there are some things that we do need to check to see where the vitamin levels are. Vitamin B12 is the most common one that's associated with dementia. And sorry, the vitamin B12 is the most common one associated with memory loss. Okay. And so we would want to make sure we're repleting or giving them back that vitamin B12. The other vitamins, the other parts of the B complex, they're important as well, but it's not necessarily associated with memory loss. There's some data, some conversation about impact of vitamin D, kind of if that's involved. But I personally think that's just engagement with outside and trying to get your vitamin D from the sun. But there's some data that suggests that you want your vitamin D to be normal as well. All the other vitamins aren't really associated with memory loss per se. But not that I want your vitamins to be low. I don't want you to have them low, but it's not that if they're really low, it's going to cause memory loss. The problem that we come in contact with a lot with patients with vitamins is because there's a vitamin out there for everything, they start focusing on using those more than their prescription medications. Okay, because they'll say, I don't want to take a statin, but I want to take the medication that I got from a health food store that said this is good for cholesterol. And then when we're trying to monitor their medication use, they're bringing their bag of medications. They only got 3 prescriptions, but they got 50 medications in there. And so we don't know the interactions between all those over-the-counter medications because they don't go through the same scrutiny that a lot of the prescription medications go through. Because the thought is that they won't hurt you. Because of this individual medication, it won't hurt you, but we don't know how it interacts with these other 40 that you're taking. Is it going to increase the amount of this certain vitamin and you'll have too much of it, which can cause a problem? So you have to think about things like that. But does that make sense?
Yeah.
So I would say from a vitamin standpoint, D and B12, if you want to focus on this.
What was that again?
D and B12. D is getting a lot of attention now, but B12 is the main one.
Okay.
It's German.
There's no hands online.
Okay.
Whoever it is.
Oh, no, it was
last
actually her.
question.
Oh, no, it's so
Gonna be last
I'll
question.
take these last. Can I take these last 2?
Go ahead. No, you answered mine already.
Oh, I answered?
It was about the stat.
Okay, got it. There you go. So you got the last question.
I'll get the last one.
Yeah, I have read online and different, that using aluminum foil and, different things in deodorant to cause Alzheimer's. Is that true?
So there are a lot of things that you'll read online. A lot of this is conversation pieces that have come up along the way. Some people say drinking certain types of coffee can be associated with memory loss. I don't have enough data to comment on it, to be honest. But I do know there are some conversations about metals in general. So aluminum and deodorant can be associated. And that sort of hints at what she was saying earlier about there are some potential environmental causes that we may think that can contribute to memory loss in general. And I want to be very clear that there's a difference between memory loss and cognitive impairment. So memory loss is what we expect. Okay, that's with normal aging. That's a process that we go through. But we worry about when the memory loss starts to impair us cognitively, so it impacts our function. Okay, but there are some data about just metals in general and exposure.
Okay.
Yeah.
Okay, this is really the last question.
Okay.
The last question.
Can you elaborate on the swallowing, when they lose the ability to?
Okay, great. All right. So that is in the severe stages. As I mentioned, in the severe stages, it's less about memory, but understanding the processing that's going on, right? And so, the one I mentioned earlier was remembering they need to turn to prevent skin breakdown. So swallowing, which is what we do every day, is a very complex process. We don't realize how complex it is and how there has to be a God because that process is going on and we're not thinking about it, right? But so at the back of your throat, there are two tubes. Okay. One going to your stomach, one going to your lungs. Okay. So your brain is programmed that it knows the air goes to the lungs and food and everything goes to the stomach, right? But as the disease progresses, I want you to think of it as a problem with signaling. So your brain, which has been skilled to coordinate swallowing, can sometimes lose that ability to know air goes here, food goes here, okay? And sometimes as you're taking it, whether it be the medication you're taking, because you're at the end stage, the medication, instead of going to your stomach, goes into your lungs, that air, right?
Yeah.
And that process of covering this up, so it only goes here, is disrupted with progression of the dementia in severe stages. And so what happens is things go into the lungs where air is supposed to go, and your lungs say, here. You say, get it out. And what does it make you do? So your body say, get this out of my lungs. Like it's not supposed to be here. So you start coughing. Okay. In dementia, when it happens at the extremes.
Yeah.
It happens with the thinnest liquid, which is what?
Yes, water.
Water is the thinnest liquid. So you're drinking it through a straw. So it's going to the back of your mouth very quickly, and your body not ready for it. It goes straight into the lungs. They start coughing.
Yeah.
Or it happens with steak.
Yeah.
The thickest solid. And what happens there is you're chewing, they're chewing, the patient's chewing, but it's steak. So you have to chew it very finely before it goes down. So they're getting tired and their brain is not telling them don't chew it enough like you used to. And it goes to the back of the throat and then goes down into the lungs and you cough.
Yeah.
Cough, right? And you want to get it up, right? And so that's what's happening. And that's what they call aspiration.
Right.
So they're going, things are going into the lungs that should not be there. Believe it or not, we do that as well.
Yes.
Okay. But we laugh it off. We like, it went down the wrong pipe. It's not wrong pipe. Right. But that's because we run our mouth, we doing other things, trying to swallow, right? But in the disease process in the advanced stages, they can't control it. So it's going down the wrong pipe, but they don't know it went down the wrong pipe. They just start coughing. So you'll see that. So think of it as a problem with signaling. Your brain sending signals to different parts of the body telling you what to do.
I said that was the last question, but is there anybody currently caring for someone with, because we had some questions, generalities, if you're interested, but if there's anybody currently caring for someone with dementia that has a question, I do want you to be able to ask it. Okay.
Saying along the lines of swallowing. So at this point, my husband sucks his medication and sometimes chew it. So is that a reason still? Because sometimes he can swallow it, sometimes he can't.
So that will probably be on a case by case basis depending on the medication. Okay. I will probably be cautious about him taking it in general. There are some medications can be crushed. Some can. They can be crushed. They can be included in things that could, because you can sort of stimulate the person's brain enough where they will want to swallow appropriately. And that's why you thicken liquids.
Mhm.
And so if you thicken liquids, it slows down the transit to the back of your throat. So it sort of gives your brain some time to kind of wake up and say, okay, this goes to the stomach, you know what I'm saying? So, but the reason why I say it's a case by case basis, because there are some medications that you can't crush because they don't need to start working until they get to the stomach. The acidity, the heat of the stomach is what gets them working. So if you crush it before you put it in, it ain't gonna work, because it needs to be heated by the stomach. So it's looking at different medications and seeing what's appropriate. If they're okay with you crushing the medications, let's crush them, and that's including the alcohol, so what we can try to get one of these. But sometimes you can't crush medications because
Yeah, find out.
All right, clear?
Thank you.
Thank you, Dr. Jarrod.